pleasure now to introduce Dr. Shishehbor, who we owe a debt of gratitude, not just for being co-director of this meeting, but for his major contributions to critical limb ischemia. I can only imagine after sabbatical in Costa Rica, you've written about 10 more papers.
No, my wife would not allow me to do that, sir. Sorry. Well, thank you very much, John. A lot of the previous speakers have done a fantastic job of highlighting some of the limitations of the perfusion devices that we use. So I'm going to, for the sake of time, skip some of that. But basically, we understand now that when it comes to ankle brachial index, if it is abnormal, it is helpful. We know the patient has PAD. But if the ABI is normal, that does not really give you enough information about the perfusion of that patient. So this is an example of a patient. You can see that the ABI is 0.56. The patient has a full thickness ulceration at the base of the first digit, the great toe that was previously amputated. You look at the angiogram, patient has significant disease here, and there is one vessel runoff. We take the patient in, we fix the inflow, and we have a nice result after atherectomy and DCB. Patient has one vessel runoff. We repeat the ABI. And we see that the ABI has now normalized to 1.12. We have excellent waveform, and we are happy. We fix the inflow. We don't have to give the patient any more dye. She is going to do great. We give the patient instruction to stay off her feet, and we are doing debridement and great work. But unfortunately, the patient comes back with this kind of ulceration, and you're wondering what happened. And you ask the patient what's going on, and she tells you that, Dr. Shishehbor, you told me to stay off my feet. So I've been sitting in bed all day to try to stay off of my feet. Meanwhile, she ends up getting a pressure ulcer involving the heel. And because you have that ABI that has normalized and those waveforms, you're like, well, maybe this is just a pressure ulcer. Maybe I can wait. Well, unfortunately, the ulcer gets bigger, and we all know about heel ulcers, as Dr. Armstrong discussed. So we can go in, and I'm going to skip the fancy stuff. But the bottom line is that we can go in, we can improve the perfusion, and now that we have improved the perfusion, we can aggressively treat the patient and heal the ulcer. So you got to be careful with the ABI because it can really lead you in the wrong direction. And we showed this with the work of one of my fellows, Dr. Bunty, that 29% of the patients with CLI have near normal or normal ankle brachial index. So if ABI is normal, you cannot rely on that. We then extended that work with one of my other fellows, Dr. Hamad, and we showed that from the data from Medtronic Impact Deep trial in over 400 patients, that when you look at these patients in the core lab adjudicated angiographic database that is international, if you see patients with three vessel disease, 28% of the patients had either normal ABI or a non-compressible ABI. Normal ABI or a non-compressible ABI. So we can't really rely on this technology alone to help us decide whether the patient requires revascularization or not. Now, there are other modalities that can be used. Briefly, some folks mentioned these. There's TCPO2 that can measure oxygen tension 1 to 2 millimeters deep within the tissue, and it can also help with hyperbaric oxygen therapy need. Classically, it's said that 40 is the cut point that we can use in these patients, and this can be affected by a number of other issues such as skin thickness, edema, inflammation, and others, and it takes about a couple hours to perform this perfusion assessment with transcutaneous oxymetry. And you can see when you measure the patient, you get various numbers, and these numbers can be all over the place. So you can get some that are low and some that are high. At the end, you have to use your clinical judgment in making the decision. But importantly, I think if you start the oxygen here on the patient, you see that none of the leads actually improved with 100% oxygen given to the patient, which I have learned that this is an indication that the patient has very poor collateral formation. So basically, blood is not getting there. So despite giving the oxygen, you're not getting blood. You send this patient to hyperbaric oxygen therapy without revascularization, you're probably not going to get much benefit from that patient. Another tool is skin perfusion pressure. It is easier to perform. It measures the opening capillary pressure and is not affected by skin thickness, edema, and heat, as we discussed. This has also been said that 40 is probably the cut point. But again, with all these cut points, you have to use your clinical judgment. I don't think we're comfortable enough to really stick with these numbers. We have to use your clinical judgment and kind of discuss the case with your team. There are other technologies. There is endocyanide green to assess microperfusion. This has been studied in single center institutions. It's been used for breast reduction and gut surgery. I think that it may have potential, but honestly, I don't think it is yet ready for prime time in assessing microperfusion. And when you do this, actually the area where the ulcer is lights up the most. And there is various things that they look at, such as ingress and egress. But again, there is some limitation because of the inflammation. Actually, the area around the ulcer is what lights up. And you're trying to kind of differentiate whether there's perfusion there or not. So the company, I believe, has to do much work. This is the work of some of our friends from Yale, Dr. Mehdi and Mitch Stacy. They are using, SPECT imaging to try to understand perfusion, but more in a setting of research and maybe pharmacotherapy in setting of trials to assess biologics and the angiosome concept. I think for clinical use, probably sending patients for a SPECT imaging may not be realistic. There is this technology from a company that you can inject these collagens under the skin. They can stay there for up to 3 years. They can continuously measure oxygen. And this is a study by Miguel Montero Baker, where they showed they can assess with these microsensors the level of oxygen indices under the skin. Again, it needs to be reproduced, and this is not available in the United States. It does have CE mark in Europe. And there is laser and other technologies that are being evaluated now in trying to understand. So obviously, there is a limitation. We don't know how to assess perfusion in patients that have normal ABI. So 30% of the patients, we are struggling, and we're trying to understand. There is other tools because we want to understand what to do within the procedure. So we know that patients have multiple tibials. There is the pedal arch that our friends have discussed. When do you stop when you're treating these patients? Is one tibial enough? Do you need to open the pedal arch? Do you need to open everything? So we are struggling because we don't have any objective measure to help us during the procedure. And there is tools such as looking at the blush, but it's a little bit subjective. Depends where you inject, how hard you inject. But it's another tool that has been validated by some of our colleagues in Japan. And then there is others such as Indigo Carmine, and Dr. Rombach is also an expert, and he's shown that you can use some of these colorful injections to try to understand where the dye goes, and basically use that as a tool to help you intraprocedurally to decide, okay, how much do I need to treat in this particular patient? And thank you very much.